We're working with NHS IQ to support learning and diffusion of ideas between pioneer sites. This is our first Hangout on air, talking with the sites about how they're developing workforces for integrated care. Get involved on Twitter with hashtag Integration Pioneers, or through the Q&A box that you should be able to see on your screen. We're joined by colleagues from Torbay, Islington and Worcestershire, and our host today is Matthew Horn, who I'm going to pass you on to now, who's going to say a few words.
Okay, thank you, Frank, and good evening to everyone. My name is Matthew Horn. I'm a partner of the Innovation Unit. I'm very pleased to be facilitating our conversation this evening. We're going to be looking at how we create workforce for integrated care over the coming years. The running order, we're going to take things in. We're going to start with a short presentation from Torbay and have a discussion, followed by our presentation from our colleagues from Worcestershire, and we will finish with Islington. We'll have about 20 minutes on each of those presentations. A short presentation followed by clarifying questions and feedback and discussion. So I expect that we will wrap this up in about an hour and 20 minutes or so, if all goes to plan. Before we start, I would like us to do some introductions. So we're just going to go around very quickly. If you can just say who you are and where you're from. As I said, I am Matthew from the Innovation Unit. And Sanjeev, would you like to introduce yourself, please?
Yes, I'm a GP in North London, and I'm also Director of Primary Care Education and Development for North Central and East London, Letby.
Thank you. Jo?
So I'm Jo Savage. I'm a GP and also the Joint Clinical Vice Chair of Islington CCG. I lead on integrated care specifically, and as a byproduct of that very much now around developing a workforce fit for the future, particularly mapped to integrated care.
Fantastic, thank you. Frances?
Hi, I'm Frances Martin. I'm the Programme Director for Well Connected, which is the Worcestershire Integration Programme.
And finally, Bob.
Good evening, everybody. My name is Bob Brown. I'm Director of Nursing and Professional Practice in Torbay and Southern Devon Health and Care Trust. This evening, I'm speaking on behalf of my closest colleague in South Devon Healthcare Foundation Trust, that's Jane Viner, and also my colleague Louise Hardy, who's Director of Integration, leading the Pioneer Programme. I hope I can give a joined-up perspective on the work that we're all doing together with a number of other stakeholders.
Thank you, Bob. And I should say we may be joined by Jane shortly, if the technology allows it. Now, workforce issues in relation to integrated care covers a whole range of things, from role redesign to culture change and culture management and change management, professional behaviours and values, the engagement of patients, carers and service users, and the development of professional integration and workforce development strategies. So we will be covering a lot of these issues, but I have to kind of remind us why we're starting with this focus. We ran a poll, an online poll on iCase, the web platform for the integrated care programme, and this was by far the most popular issue and the thing that was causing most interest and concern. And it is a perennial issue when we are dealing with integrated care. So it is a hot topic, and we're going to start first of all by hearing from Bob from Torbay. So Bob, if you could just take the next 7 minutes or so to set out some of the successes, the challenges and the lessons from your work in Torbay.
Thank you, Matthew. Well, really from last autumn, whenever as an organisation and as a group of partners, we became one of the pioneer sites. We have set about developing a programme of work which Louise Hardy has been leading on behalf of the CCG, working across each of our organisations and involving local councils, Health Watch and so forth. And our ambition is to develop really joined up care for everyone across all of southern Devon and Torbay and beyond. One of the factors that we face on an annual basis within the geography of our area is the fact that the population swells by over 100,000 in the summer months, and that is a factor that we have to bear in mind when we think about integrated care, both health and social care. So our ambition is around excellent joined-up care for all of our citizens. And I know that having looked at the work that's being done nationally in terms of the integration pioneers, a lot of what I'm about to say in the next few minutes will be quite similar to, I think, what other colleagues are doing. And certainly Jane Biner, my colleague in South Devon Healthcare Foundation Trust, has led the way on developing this, let's call it a concept around the whole lifespan, from early years through childhood to young adulthood, active aging, and over time to frail elderly. So we call that the life course model, and our ambition is to enable young people to start well, to develop well, to live and work well, and to age well. And the demographic challenges that we have in South Devon and in Torbay are very similar to what other colleagues will experience. We have a lot of issues in terms of young people's health and safeguarding and substance misuse, and also teenage pregnancy. In parts of Devon and parts of Torquay, for example, there would be two of the top 20% areas of deprivation in all of England, and we also have in parts of Devon, in our trust area, we would have 8 to 10% more over 85s than in other parts of England. So we face many challenges across the life course, and as pioneer organisations, we're focusing really in developing our plans around three key areas. The first one is around developing better transitions for young people as they move through services between childhood, adolescence, and adult services. The second area of work is around this topic of substance misuse, and the third area is around frail elderly and older people who have comorbidities and who require a lot of dedicated focus to try and ensure that they can stay safe for longer at home. And I think that's similar, as I say, to some of our other colleagues' work. Just to turn for a few minutes to workforce, Jane and Louise and I facilitated a workshop across both trusts. So I am the Director of Nursing in the Community Trust. Jane is the Director of Nursing in the Acute Foundation Trust, and Louise is the CCG lead. And we facilitated in March a workshop with a whole range of multidisciplinary colleagues to focus on the topic of workforce planning over the next couple of years to develop the integrated workforce to lead integrated care. And there were many themes that come out of that workshop, and I'll maybe touch on a few of them if you're happy, Matthew.
Yeah, please do.
Yeah. I think the first message I would say is that if we're going to enable people of whatever age to stay safe in the community, to have good quality of life and good quality of care, the health and social care workforce is only one part of the solution. So we must work in partnership with many other agencies, including social housing, security, policing, exercise, fitness regimes, schools and colleges, to be able to develop the workforce of the future. For example, developing apprenticeship schemes and strengthening across a whole range of areas of provision, training and develop to enable people to look to self-care and look after themselves. And the whole topic of health promotion and self-care and health protection is a key part of future role development. And we could talk at length, I'm sure, each of us as pioneers, about the future nursing, medical, allied health professions, pharmaceutical, GP workforce, practice nursing, but ultimately it's going to come down to how the public work with us to care for people in the community looking forward as well. So I think that's my first main point about the future workforce. The second one is that we need to develop a partnership approach to workforce planning, and one example of that for me is that from a nursing perspective, to be able to manage people with a number of comorbidities, and 40% at least of our population are living with 4 or more long-term conditions, nursing needs to respond very differently and perhaps be much less focused on specialist care and more so on strong generalist care across the hospital community primary care interface. And I think the same applies for medicine. GPs enriching into hospital services traditionally, and particularly hospital doctors outreaching into the community to develop workforce plans in partnership that enable people to feel safe and secure across health and care pathways. As far as the model is concerned in South Devon and Torbay, like other areas, we have a focus on developing integrated care hubs. And an integrated care hub, by definition, is a solution within the community whereby people who require support can access same-day assessment, diagnostics, treatment, and signposting. And I think that the term hub is receiving a fair amount of attention, but still needs a lot of thought in terms of what that actually means in terms of the future workforce plan. And this evening, I hope to learn from other colleagues who might have a view on this term integrated hub. And as I move towards conclusion, I would just also say that working with our academic partners, working with colleges to develop the future workforce in terms of both apprenticeship and preceptorship programs and succession planning is going to be crucial, and also in terms of leadership development, because for me workforce planning is part of developing the leadership of the future to deliver safe and effective care across this life course that Jane and Louise and I refer to. So finally, part of that is about good supervision, active learning, being able to develop rotation between hospital and community, shadowing, and being able to mentor and coach the future workforce as they develop a much more integrated view on things. I think, Matthew, I would like to maybe leave it at that point.
Thank you, Bob. So, consideration of the non-healthcare workforce, how the public will work with us, change of roles in relation to health promotion, partnership approaches to workforce planning, integrated care hubs, colleges, apprenticeships, training, and professional development. Let us take some really questions for clarification. We'll take some from each of you, and then we'll ask Bob to respond to all of them. And I'm going to come first to Sanjeev, and then I think I'm going to go to Joe, and then Francis. So Sanjeev, questions for clarification, really.
I was interested to hear about your integrated care hubs in a bit more detail. What do they actually entail? And what kind of size of population do they serve?
Great. Okay, that's clear. But just hold on there, Bob. Hang on. We'll just take a few more. Joe.
So for me, I mean, there are so many synergies with the work that we're doing, but I'm going to ask specifically about your apprenticeship scheme. So certainly in Islington, we're looking at a sort of employment commission, which is looking to how we can develop apprenticeship schemes. And I suppose it was really to ask you where you are in your sort of development of that.
Fantastic. Thank you. Francis.
Thanks. There'll be lots of familiar themes as we go through. I think just wanted to talk. You mentioned having a workshop in the combined CCG and the two trusts. How much have you got a joined up workforce plan? Because we've got quite individual organisational plans. So have you got a single whole system workforce plan?
Great. Good mix of questions, Bob. Off you go.
Okay, I might need to ask for the questions to be repeated, but I think I'll start with the last one. We do across both trusts have a workforce plan which is multidisciplinary and joined up. I should say that South Devon Healthcare Foundation Trust and Torbay and Southern Devon Health and Care NHS Trust are working through a transaction process to become a single integrated care organisation over the next year. So we would hope by this time next year we will be a single foundation trust, which is in keeping with the vision that we're all talking about, and that's good. But we currently have a joined up HR, personnel and organisational development function, and the leadership within that function is developing and has been for some time, creating a single workforce plan, and that's, as I say, across all professions. So I hope that answers your first question.
That's great. Thank you, Bob. The next question was around your integrated care hubs. What do they entail? Can you just give us a bit more detail?
Yes, Sanjeev asked a very good question, and as I said, there's still a lot of work to be done to determine the definition of an integrated care hub. But for me, it's a single point of contact. Whether our focus is particularly around people who are older and frail at present, but in our area, and your question was also about the population. It could be anything from a small group of 2 or 3 GP practices serving a population of 10 or more thousand, or it could be up to 20 or 30 GP practices serving a population of anywhere between 40 and 80,000, and we're still determining that, Sanjeev. But what I would say is that our vision for an integrated care hub for an older person who is frail is to try to provide a same-day diagnostic service that enables an older person who has long-term conditions, who can quite regularly get into crisis, and that's where we're trying to prevent the blue light ambulance from taking an older person to A&E and when they have COPD or heart failure, and try to get ahead of that crisis, whereby they can have a hub will provide same-day diagnostics and support and signposting and access to rehabilitation in likely a community hospital site rather than in the DGH or the acute facility. But we envisage that both our DGH and one of our community hospitals will work in partnership to provide that. So the consultant geriatrician may work with the diabetologist and the COPD consultant, along with the allied health professions and nursing, to provide that access to diagnostics and support in the hub, an onward referral. And the onward referral may be to the community nursing rapid response team or to community rehab, so that person has continuity of service as opposed to getting closer to crisis where they end up in A&E. And we hope that by working in partnership with the voluntary sector, Age Concern, for example, we will be able to provide an ongoing range of support that enables people through volunteering to maintain day-to-day contact that keeps them out of crisis as well. Okay,
thank you. Let us look at the last question, which Joe was particularly interested in, the apprenticeships that you talked about. Could you just add a little more on that, please?
Yes, I'm relatively new to working in this area, and Jane Viner, my colleague, who's Director of Nursing, knowledge in this. But South Devon College has been working very closely with both trusts for a number of years now to develop an apprenticeship model. And there are a range of modules and programs which enable young people, and not necessarily just young people, to access a program of work which enables them to pave their way into the health and care professions. And it's a well-established program now with South Devon College. We'd be more than happy to share the vision and direction of that, but certainly I would just say at this stage that Jane and 1 or 2 other colleagues would have a stronger knowledge than that on me.
Thank you, Bob. So Sanjeev has asked in the chat bar if we can ask follow-up questions. We certainly can. Joe, let's just stick with this apprenticeship point. Do you have any other follow-up questions or responses you want to give for Bob?
I suppose from our local narrative, it is very much something which is specifically being developed by the London Borough of Islington. And one of the experiences is that we get people onto the apprenticeship scheme, but often it's actually very difficult to get people into the clinical role phase. And it's really all around the management of risk. And so what often happens with the apprentice is that they end up doing performing office functions or administrative functions and never really get the exposure or the experience to the sort of to the delivering care. So I suppose it's quite how one integrated that into the module of learning and how one managed the risk that was associated with that.
Well, my response to that at this stage, Joe, would be that the apprenticeship scheme with South Devon College is specifically focused on clinical pathways and enabling these young people to embark on a program where they can combine college-based learning with local clinical experience.
Fantastic. It'd be really interesting to talk to you at a subsequent point about that. Thank you.
Okay, thank you.
That's great. Sanjeev, I know you had some other questions.
Yes, thank you very much. I'm really very interested to hear about this approach, because for me, one of the issues about primary care is the need to develop capability and capacity. And I'm interested to hear how the hubs will support the development of capacity and capability for looking after, for example, the vulnerable elderly in the way that you describe. And the second is, for me, is the issue about the risk of segmenting the population in a particular way, which may understandably focus on the very young families or the very vulnerable elderly. But what about the group in the middle? How do you sort of begin to start planning care in such a way that no one is left out of this kind of sort of progressive developmental model? Have I made myself clear?
We may. Bob, are you still there? So I think we may have lost our link with Bob. Frank, am I right?
You appear to be right. I mean, usually he won't have left the call, because if he did, your box would disappear. But
he might be suffering interference, or he may well have muted. No, he may have muted. He's not on mute, is he?
No, he's not on mute.
So what I would like us to do, bearing in mind this is recorded and Bob will be able to watch this, the bit that he missed. What I would like us to do is move on to some of the feedback. Frank, if you could just mute, your screen. So what I'd like to do is just get some feedback from colleagues around what we've heard from Torbay. And could you share with us the things that you liked the sound of, that you thought were real clear strengths, and what if you could offer advice or suggestions to Bob and Joe and the team in Torbay from your own work. And I'm going to go first to Francis. So Francis, what did you like? What do you think was the strengths? And have you got any suggestions or advice to share with colleagues from Torbay?
Well, really like the idea of a joined up HROD function. I think having that sort of level of strategic collaboration between providers has got to be the answer. And certainly picked up this thing about apprenticeships. So I think those are two things that we would really want to emulate in Worcestershire. I suppose one of the things that the sort of legendary about Torbay and South Devon is that they've been at it for a long time. So I suppose that there would be something in terms of reflecting the journey that they've been on and being able to map at what point they had the strategic discussions to be able to get to a position where they have the maturity of relationships. So it's more of a kind of a slightly rhetorical question, really, is that, you know, what was it about the maturity of the relationships that enabled them to get to that point? But certainly the joining up the strategic functions and investing in the long-term planning of the workforce for the future, not just responding to this year's crisis, I think is really good.
Thank you. Any suggestions or advice for Bob?
Get your colleagues to be on the call with you, probably, and, you know, well done for leaving Northern Ireland, wherever you came from.
Okay, let's move on to Joe. What feedback do you have for the Torbay team?
So, I mean, I felt that, as I said again, there are very many similarities to the work that we're doing in Islington, and I think certainly the interesting part for me is about your broader partnership. So often we focus very much on our immediate partners, but there really is a big part around the development of the social asset piece, which I think is going to be one of the keys to our long-term sustainability, really, as organisations, but also bringing in the broader scope of partners, so certainly housing, the police, schools and colleges. And I suppose it's about how you do that in a timely way, because obviously, we have our strategic imperatives that we need to deliver in a timely way, but and how one balances that with making partnerships too sort of unwieldy, but I think that for me was a very strong point, that you were already having those collaborative conversations. And I suppose the other thing was to hear that despite, I suppose, we hold you in great esteem for a sort of long trajectory of development, that you're still having these nascent discussions about the meaning of the integrated hub, about the sort of the number of the population that it will cover, around the key elements of it. I mean, I suppose we often feel that we're a little bit behind because we're still having those discussions, but I think it's a commonality that, these things take time to actually develop and come to fruition, in a meaningful way. So those are really my comments.
Thank you.
Thank you.
Sanjeev, strengths that you admired, and suggestions or areas for building that you can advise or suggest for Torbay.
I agree with what others have said about the idea of an integrated approach to HR, organisational development, education training. I'm delighted to say it's a unique thing. I've never come across it quite as well described as that before. I think the notion of this well-developed relationship between the Director of Nursing, the Director of the Community Trust, and the CCG Education Workforce Lead coming together and actually working in partnership is actually to be welcomed, and it's a clear sign that actually if you can get people to work together, you can emulate that in the way care is also delivered. I think that's a really positive thing to see. Areas for consideration, I think, are to do with thinking a bit about the capacity and capability of primary care in its current state to support the integrated care hub that you're kind of sort of beginning to kind of evolve. And the second is both the benefits of segmenting the population in the way I think that you're describing with the vulnerable elderly and young families, and thinking a little bit about some of the downsides of that as well, particularly the loss of continuity of care and the continuity of service for families and groups of people. So it's just those thoughts that were going through my mind as I heard Bob talk.
Thank you. Thank you, Sanjeev. I guess if I were going to pick on two other things, I would pick on the question of leadership, which you mentioned, Bob, and how you develop the leadership capabilities across all the partners to deliver this kind of change. And I think probably your thinking on that is more advanced than we've seen elsewhere. And the other thing that struck me was it seems like you're building the culture and relationships first, and then the structural changes following. And so often we do it the other way around. So some reflections on how you, recognizing that simply creating a single unified integrated care organisation and a new structure won't necessarily deliver the cultural changes that you need. How you get those two things to work together. So there is some feedback from all of us. This is your last opportunity to respond, Bob, before we will move on. So just if you could just pull this together for South Devon and Torbay, that would be fantastic.
Thank you, Matthew and colleagues. I lost a couple of minutes in the call, so I'm apologies, but I came in just to hear most of the feedback. Thank you, everybody, for your feedback. There's a lot there, a lot that I can bring back and discuss with Jane and Louise and quite a number of others. I think that I don't want to take too much time, so I'll just take 1 minute to say that the whole challenge of developing the future workforce to create safe and high quality integrated care is one that is going to take some time and a lot of energy and very clear focus. So that point around leadership that you made at the end is probably the one that I'll emphasize. Each of you have said something important, and I'll note that. But if we don't have strong, committed leadership at all levels of the workforce and across agencies, we're going to really struggle to develop integrated care within a continuing time of austerity whenever we continue to face and will face even more demand from demographic and comorbidity challenge. So thank you.
Brilliant. That's great. Thank you very much, Bob. You set the standard high for the rest of the session. We're going to move to Francis now, and I'm going to ask Frank to bring up a slide on his screen and share it with everyone, which unfortunately means, Francis, we won't be able to see you for the next 5 minutes, but we will, I am assured, be able to hear you. And Frank is just bringing that up now.
Okay, I'll start talking while Frank does the technology. So, assuming you can all still hear me.
Yes, we can.
Okay. So the Worcestershire Integrated Care Programme is called Well Connected. It tries to be like Ron Seal and do what it says on the tin. And I'm in the very privileged position of being employed jointly by the 3 clinical commissioning groups, the County Council and the 2 main provider trusts, working across the whole system with social care. So it is a whole system approach. We have focused particularly on older people with long-term conditions, complexity, which is one of the elements that Bob was talking about. We're not excluding other sections of the population, but our combined collective responsibility. So we've agreed a vision that in Worcestershire by 2020, individuals, families and communities will be supported to take control of their ongoing health and well-being and look after themselves to have as healthy and fulfilling lives as possible. And that everyone will have a proactive care plan where that is appropriate, and the plan will be owned and developed with individuals and their families, and everybody who's working to support them will have been putting into that. And then if people need specialist care, there will be a partnership between the extended primary care team and secondary care, rather than the handoffs that we traditionally have when somebody crosses the threshold of an acute hospital. So very happy to share the kind of more detail behind that. So we have recognised that the current system of organisational boundaries and professional boundaries gets in the way of people having the experience of care that is better for them. So we've got a history of using some flexibilities under Section 75 to integrate some services, some really good experience with mental health and learning disabilities particularly. But we also, a couple of years ago, closed longer-term rehab wards in the acute trust and TUPID staff across from both the acute sector and the community into a new rehabilitation unit managed by the County Council. So it was a kind of leap of faith, so it's now CQC registered by the County Council, employing clinical staff who were traditionally employed by the NHS. So part of our plans are predicated on the fact that without the right people with the right skills, we're not going to deliver the right care, but also recognising that every health and social care economy in the country wants to recruit community geriatricians, they want more GPs, they want people who can manage acute stroke, people who can do comprehensive geriatric assessment. So we can't recruit and retain those people quickly, so we have to find ways of providing those skills within the existing workforce as we try and grow a different workforce for the future. So really good relationships with our local university that does most of our pre-reg nursing for nursing therapy and social care. A lot of synergy on the curriculum, but also encouraging them to teach people together so that they learn together, as well as having core curriculum components. Definitely concerns about primary care. There's been, in Worcestershire, significant reduction in primary care capacity at the time that we're wanting to increase it. So that's one of the, on my worry list rather than solved bits of the conundrum. But we have made significant progress in training and skilling people to provide generic skills across physiotherapy, OT, speech and language therapy, and nursing and care things in the community to a kind of level 4 capacity. We haven't got it all sorted. One of the things that Bob mentioned earlier was around language. We use language differently to describe things, and a care plan means something different to an individual, to a GP, to a social worker, to a therapist. So we have to try and agree on the language that we use to describe what we want. I think there is something about challenging some of the status quo. It's not that many years ago that you had to be a doctor to take blood. Now the last person you want taking blood is a doctor. What you want is one of those nice phlebotomist people, because they're going to be an awful lot better at it. So there's something about when people say you can't, trying to say, okay, so what would enable us to be able to do things differently? And picking up some of the stuff that Bob said about leadership, we are working towards much greater partnership between our component organisations, and one of the bits of support for us as a pioneer is some leadership development capacity through Public Health England and the Systems Leadership Academy. So we're trying to make the best of the workforce we've got now. The people that work in Worcestershire are the people we're going to continue to need to work in Worcestershire, but where they work and how they work needs to change. Okay, happy to stop. I've now lost you.
Thank you. Thank you. Yeah, I'm sorry, I'm back. And we have your slide on screen. So let us just turn for clarifying questions. We'll just take it in turn again. I'm going to start with Joe, and then I'm going to come to Bob, and then Sanjeev.
Gosh, I suppose I've got so absorbed. There are so many similarities. So I suppose it's around your post. You certainly, the recruitment of your post seems to certainly be a very sort of a joint post that covers a number of organisations. Can you tell me a little bit about the history of that recruitment process, I suppose?
Okay. Shall I take all of them and then come back to them, Matthew?
Sorry. Yeah. Sorry. Yes, you're quite right. Bob.
Yeah. Thank you for your presentation, and there's a lot there. Joe's right, and I would be interested in hearing a little bit more, not necessarily by way of clarification, but just your views on how care centred around a GP practice can be best delivered with a multidisciplinary team that might have a tendency to have a hospital focus traditionally, but we want to get them outside of the walls of the hospital, working with the voluntary sector in the community. So just interested a little bit more on centred around GP in the community.
Thank you, Bob. And Sanjeev?
Yes, I was interested to hear about your focus on the existing workforce, and I'd be interested in a bit more detail about how you are working to support the development of the existing workforce into new roles, and also how your LETB is supporting you in that journey as well.
Thank you. Francis, 3 good questions there.
Okay. Right. Start with Joe. Yeah, my post. The integrated care program really grew out of an acute services review that says in order to have sustainable acute services, it was no longer possible to recruit the right number of people and to maintain them on different sites, and therefore we need to shrink the acute footprint and reorder where things are. So much more care needs to be happening in the community, and that's really where this cohesion came from. I think it's an enormous privilege to be where I am because I don't have any organisational allegiance. So I'm employed to look after the best interests of the just under 600,000 people in Worcestershire. I report to each of the boards, to all of the chief executives, and to kind of publicly accountable to the people of Worcestershire. My personal history is that I've never directly worked with social services until now, and not had such strong relationships with the voluntary community sector as we do, because they're one of our formal partners through Age UK. But I've worked in every bit of the NHS, so I've got the badges in terms of something about some credibility of understanding some of the challenge. So it's not perfect, but it really does help, I think, in terms of challenging some of the things to say, is this right for the people of Worcestershire, or is this right for an individual organisation?
Mm-hmm. Thank you. I'd love to ask another question, but I'll wait my turn.
Okay. Bob, general practice is the bit of the NHS and the social care system that the public tell us they know, love, trust and understand more than anything else. The public aren't very interested in CCGs, in trusts, in the TDA, Monitor, NHS England and all the other bits that we carve ourselves into. And I think there is something about trust and confidence of the family doctor. But we know that the breadth of work and care is not confined to medicine. So we've got some very natural communities, so there isn't a kind of one size fits all. You were talking about the size of your hubs. We have some practices that very naturally group together into something that is a cohesive community, and therefore they can do more sharing of staff across teams. But there are a couple of places where it is a single practice, with the team based around that and providing that care and support. We're also working, as I say, with Age UK and other voluntary community sector organisations, and I think have been very inspired by some of the work in Staffordshire from the No Still project, but also from Cornwall with the Newquay project, about recruiting people who come with the badge saying, I've come from the doctors to help and support you, in a very non-clinical way, particularly supporting carers to be able to continue to provide that vital support function. So there's something about using the absolute strength of general practice. One of the key enablers for us is that all of our practices, we've got 66 practices in Worcestershire, and they've all moved to the same IT system. So there's something about being able to share wherever people appear in the system, and changing some of that in out of hours care. But the kind of the confidence that the public have in general practice.
Francis, just to push you on this, I think Bob was getting at if when you build these teams around the GP practice, if you've taken the team out of the hospital, how do you take the hospital out of the team?
Yeah, and it is an issue. Everybody who works in the community will at some point have worked in hospital, or most people, lots of people in hospital have never worked in the community, and I think that change in emphasis of being a guest in someone else's home, and we know that people's tolerance of risk is very different in hospital. Once you cross the threshold, there is a different governance and risk in terms of how independent and the kind of environment in which they're living. So we've worked really hard on developing partnerships between secondary care colleagues and community primary care general practice colleagues to build those relationships where people understand each other more and can happily discuss over the telephone and share a care plan and the development, rather than having to be referred and the patient carers needing to travel.
Yeah,
thank you. And Sanji's question in relation to professional development and the LEP-B and so on.
Okay, the LEP-B, as I say, I think initially people were a bit surprised about who we were and what we're trying to do. So I've got a very able medical director colleague who works with me part-time. She only works a day and a half a week. And there's something about the LEP-B, I think they've been a bit behind the curve in terms of understanding why integration that doesn't fit into a nice, neat trust or CCG pot, and actually looking at this whole system needs. But having got into the LEP-B and the LET-C, they're now very supportive, and they've actually supported some development funding for us to do some of the scoping about our needs for the future, in partnership with some of the specifics around urgent care, which is obviously one of the key elements that we need to improve. So there's something about, again, being pretty pushy about making the relationships, because people don't necessarily appreciate what it is that we're trying to do if we don't go and help them to understand it. So once we've done that, being incredibly supportive, once we get on the radar.
Thank you. Okay, I'm going to go back to colleagues, and unless you've got a burning further clarification question, let's have some of your feedback. What struck you as kind of clear strengths And can you provide any help or suggestions for Francis? And I'm going to go to Joe, and then Sanjeev, and then Bob.
So I suppose for me it really sounded like a very grounded methodology, sort of systematic approach, and particularly the sort of the whole system approach that you're developing. And I suppose I'm still, in terms of I suppose understand. It sounds particularly like you really have achieved a huge sense of unified vision, actually, across a number of major stakeholders within your environment. Stakeholders that may have different priorities, some of whom may be slower to come to the shared vision, may have sort of different pressures. And I suppose for me that felt like a real key to your success, embodied in your joint leadership role. I think that it sounded like that development of relationship was particularly evolved. And I suppose in terms of challenge, I would say that we feel that we're probably on the similar sort of route at the moment, but it's how you really begin to develop that shared vision, not only within the sort of higher echelons of our organisational groups, but really how you develop that sort of distributed leadership and have that common voice and vision through our entire workforce, how we really impregnate that in a meaningful way. I think is a huge challenge for us all.
Yeah, absolutely.
Thank you, Joe. Sanjeev?
I concur with Joe. I mean, I think the way you are approaching it through the whole system is actually fabulous. I also applaud the sort of the recognition of the need to invest in your established existing workforce and help them move along the journey that I think you're undertaking. Is great to hear. I think there are some challenges that I hear. One of them is around the notion of the primary care and the capacity issues that you've got, and I think that's one that I think we all have in common, really. The second one is this idea that you need to carry on challenging traditional stereotypes, because if you don't do that, then I think we don't shift and move in the same direction. So I think that's an ongoing challenge that I recognise certainly in my patch as well.
Thank you.
Thank you, Sanjeev. And Bob?
Yes, Francis, thank you for your thoughts there. I would also congratulate what you're doing. It's really encouraging to hear that. And there's two things that really particularly interested me. One is this idea of a single joined-up GP ICT system, which if we could get to the point where that's integrated with hospital and community team records, and indeed the person in their own home having access to that, I think that's going to be a key enabler. The other thing that I was interested in terms of your concept of a multidisciplinary team working around GP practice is around how we engage hospital teams in the community, and I like yourself have some good experience of how that can work well. And I worked with a diabetes consultant in Northern Ireland, and there's one here in Torbay who I think diabetes we can all learn from, because it's largely a primary care condition. GPs manage with practice nurses diabetes very well, but when a person has comorbidities and complexity, you can do a lot more close to the GP practice if we can get the traditional hospital team out working in the community with those people.
Absolutely.
Thank you. Thank you, Bob. If I were to add two things, I'm particularly struck by your focus on having to change the existing workforce rather than recruit and grow a new workforce. And so one question I have really is around values. How do you begin to shape and change the values that existing workforce bring to their work, in relation to the values in the way they view other organisations and colleagues in other teams, but also how they view patients and carers and the roles that patients and carers are being asked to play, and the relationships that we want staff to develop with patients and carers. So how do you change the values of the workforce over time? and I was particularly struck by what you said about when people say you can't, and in particular the sort of behaviours around protecting existing roles. And we should recognise that actually people's careers and people's job plans and their promotions are not necessarily aligned with an integrated care model. So how do you begin to change the sort of professional trajectories and the career plans and job plans of healthcare professionals so that actually integrated care will work for them rather than the status quo?
Yeah. Yeah, I agree. Absolutely critical. Really helpful feedback from all of you. Thank you. If I just to pick up a couple of things, I think, Bob, in terms of the ICT, technology is an enabler. It's not the solution. But one of the things that was a really powerful kind of game changer was when the IT group was led by my medical director, Dr. Bernie Gregory, rather than by the IT people. Mm-hmm. So if you put IT people in charge of joining up to IT, they'll go for a perfect system, and there will always be a more perfect system around the corner. So actually, this is about being clinically led and saying, actually, the way I can provide better care and to facilitate my practice, this is what you guys need to deliver for me. And that was a really important change in the emphasis. So actually, she's kind of passed it back to one of the clever people in terms of saying, okay, we've now got the agreed strategy, you guys get on and deliver it. But it was really making it, how is this going to make a difference to people's experience of care, not what is a perfect IT system, because it was called Connecting for Health and it didn't quite get us where we need to. And yeah, Matthew, I think there is something about making sure that we use leaders in the system who are able to challenge some of the status quo and are less protective about either not wanting change because they're going soon or because they're not confident about it. And some of our most dynamic new leaders are GPs who are earlier in their careers and saying, actually, you know, general practice will need to change and you need to allow us to get on and change it now, because actually it is not sustainable in the kind of modus operandi that we've got in existence now. Thank you.
Okay, thank you for that, Francis. I think unless anyone objects, we are going to move on to our final presentation. No, nobody's shaking their fists at me. Okay, so let us move on to the final presentation, which is who's going to give this? Is it Joe or Sanjeev?
So shall I do the sort of overarching vision, and then Sanjeev, maybe I know maybe I should hand over to you to really talk about our very specific situation with the community education provider network, because I think that that's certainly something which I think we're doing a little bit differently. How do you feel about that?
That's absolutely fine. Yeah.
Fantastic.
That's great. And we've got a set of slides on our screen which Frank will take us through. And if you need him to move on, then just nudge him.
Yeah.
Okay, Frank. So, I mean, I'll just go over them fairly quickly. So I suppose really this is just to show you some pretty pictures of Islington, first of all, on the first page. We are an inner city, very diverse population, fifth most deprived nationally. But actually, interestingly, when you look at the demographic, a really very young population with a bulge sort of within the 35 to 45 age group, but also with a significant problem with long-term conditions, but particularly linked to the issues around deprivation. The long-term conditions are occurring much older and much younger in our population. So we really have had to think about sort of not just thinking about the concept of frail elderly, but really thinking about, again, a whole life course approach. And I suppose particularly our pioneer is very much focused from childhood through to adulthood, recognizing that children also and young people value better integrated care. And a little bit around the story of Islington, I suppose. you know, we do come from a history of joint collaborative working, which goes back over a long period of time. So 10 years of pooled budgets, particularly across health and social care, looking to support carers, learning disabilities, mental health. So I suppose it's on the basis of that, and quite a long history of working with the voluntary sector, and the fact that over the last, in 2009, the establishment of the Whittington ICO, which is an integrated care organisation combining community services with local authority social care element, has really, I suppose, provided the springboard for us to really begin to have these conversations around integrated care, but particularly how we can collaborate to develop a different workforce vision to map to the work that we're doing. And in essence, the model that we're trying to develop is really to develop better person-centred coordinated care, very much along the lines identified by National Voices in the information that they published last year. But for us, it really is with a strong focus on prevention, developing coordinated person-centred care, and working on the co-creating health model, which is really around using motivational approach to support individuals to identify goals, and then to support the personalised approach to sort of achieve those goals. And so for us, that's a very key element around the work, the clinical work that we're doing, and supporting that with quite advanced thinking on the development of personal health budgets. So particularly now we already have a number of patients, not only continuing care patients, but patients with long-term conditions, particularly mental health related problems, chronic pain, etc., who are beginning to experiment with receipt of personal health budgets to really support that personalisation agenda. In tandem with our new model of care, I've heard most of us have been talking about the development of our sort of locality offer, which we all call different things, but by different names, but it's really how we can begin to affect the development of a community team, which is holistic and whole system, that can support people in a better way in the community. And I suppose really thinking around how we can bring together issues around long-term conditions, but particularly the sort of parity of esteem around supporting patients with mental health problems, because certainly for us the coexistence of mental health problems and long-term conditions is a very real problem. So I suppose that's enough really around our model of care, and I suppose it's around how we have gone about developing our workforce. And I suppose this really came out of, you know, conversations and engagement exercises that we've done over the last few years to really better understand what our staff want and what our service users are experiencing of care. And certainly we've had a lot of feedback from GPs, for example, recruitment problems. We're facing a 16% retirement, I think particularly in Islington. We have a 30 to 40% cohort of salaried doctors. So it's really how we listen to what people are saying. We've performed recent research or sort of feedback looking at our community nursing services, because there's a lot of feedback that it wasn't fit for purpose. And certainly the feedback that we've received has revealed problems around recruitment and retention of nursing staff, particularly in London, problems with obtaining affordable housing. So there's really been a sort of groundswell of voice that we've garnered in terms of really being able to understand what it is we're dealing with. And I suppose Sanjeev and I met because Sanjeev, in his capacity working for Health Education North Central and East London, was very keen to develop a new system of delivering education within the community. And this was really around supporting the development of collaborative, meaningful conversations between providers and commissioners to really begin to understand what was happening at the coalface, to enable that process of organic development to really inform workforce development going forward. Sanjeev, I don't know if you want to say a little bit about the particular ethos, I suppose, the aspiration.
Yes, happy to do so. I mean, most of this arose out of a recognition that with the demise of primary care trusts and strategic health authorities, we suddenly found a vacuum in local communities around coordination and organisation of education, training and workforce development. And at the same time, we also realised that actually relationships between professions and across professional and organisational boundaries was stilted. But to add to the compound to the problems was the issue that we didn't actually know what our workforce looked like in the primary and community sector, and we didn't also know what kinds of education training needs they had, nor what kinds of future roles that they may need to be empowered to undertake. So with that in mind, we started thinking about how we could empower local communities to come together, and particularly thinking about educational networks as being a way forward of bringing together different professional groups from different parts of the system, including community, primary, acute and social, to come together around the table and talk collectively about the development of the workforce, and have the CCG engaged in defining what kind of their commissioning intentions were, so that those could feed into the development or thinking about the development of the workforce. So that's why we're sort of developing a model based around communities and local communities of educationalists, and with links into HEIs. Sorry?
So I just lost you for a minute there. Could you just repeat that?
What I said was that what we've tried to do is to engage local communities of educators to work with our clinical commissioners and our local higher education institutions to support the linking up workforce planning with education training and clinical services, and the way clinical services are moving. I think I'll stop at that stage and ask if anything else, Joe, you think we ought to add.
Yeah, so I suppose that from the experience that we've had so far, I suppose, of trying to develop our sub-locality community-based structure, there have been some real themes that have emerged, which I think have really managed to, I suppose, identify the work streams that we really feel are imperative in terms of getting the foundations of meaningful integrated care, and how we develop the education initiatives to actually support that. And I suppose for us, it chimes with what's already been said. I think there's a lot around really supporting our staff to develop that common vision and those values, because actually people are in very different places in their understanding of what the locality offer is, what the key elements of education are, what they can expect from their colleagues. There's also, as I mentioned previously, something about having the system leaders signed up to the same vision, but really making sure that that vision is held and worked, is held as an absolute goal and vision by other members of staff. And certainly we've tried to go out to our stakeholders and talk about how we should develop our locality offer. And the real feedback has been, we actually really need to do this in an organic and iterative way, and really listen to what our stakeholders are saying and what they perceive their educational needs to be. And I think the other very important thing is around developing a common language. So when we're trying to integrate organisations and integrate care around individuals, it's so important that we really understand what we're all talking about. So that is actually, you know, another very important key piece of work. So I suppose for us there are some must-dos around really, I suppose, systematically enabling that cross-fertilisation of skills across different disciplines, so that we all know how to deliver a care plan, so we all know something about a motivational approach, how to have person-centred conversations. But it is really more about, I suppose, supporting our staff to feel really engaged and to be able to really understand the vision of the whole. There is a slide in the slide deck which I won't talk too much about now, but it does talk about a very important example where it's the learning from experience, so slide 8, where we went out to our staff to sort of do a significant piece of service redesign around a community rehabilitation and reablement service. And this was really given as a sort of offering to the staff that worked in that team to really begin to do an iterative piece of work as to how that service should be improved. And I think through a process of bottom-up continuous quality improvement, they actually completely redeveloped the service. It was a small-scale pilot, which eventually it also incorporated community nursing and a mental health element. And unfortunately, because it was a pilot, it was quite short-lived. But in terms of the real engagement that we received from staff and the real passion and that going the extra mile was absolutely remarkable. And when unfortunately the pilot was stopped, because obviously it was a pilot and we needed to evaluate, there was a real, I suppose, groundswell, which was to say, no, we must continue with this. And so I suppose for us it's very important, this is a very important message, which is really around being able to devolve our leadership to our staff to enable them to really feel engaged, to make things better for patients. So I suppose I'll stop there because I'm mindful of time and we still have to take questions.
Thank you very much. Francis, some questions for Sanjeev and Joe.
And so then there was me, isn't it, really? And thank you both very much indeed. The reassuring thing is that we're all trying to do the same things, isn't it? But equally extremely helpful to hear how you've gone about it. A couple of things I wanted to pick up, particularly around parity of esteem, because it is the new buzzword, and it's something I personally feel passionately about. But you know, you've talked a lot about values and about culture and about leadership. So it's kind of, what does that really mean in terms of the emphasis that people are putting on mental health as well as physical health? How's that translating into the experience for people and the skills that the workforce need to deliver that?
So very specifically, so we have mental health very much at key partners at every level of organisational development and structure, and we, in terms of trying to begin to deliver a much more integrated multidisciplinary approach around mental health education, we have begun to develop programs whereby we are trying to upskill particularly practice nurses and community nurses in mental health related issues. We also have some new pilots working particularly around personality disorders. So psychologists who are now working in a sort of iterative way, attending multidisciplinary teams in practices, talking about supporting teams to manage more complex patients, particularly with personality disorders. So bringing to the fore the complex mental health related problems that form part of, you know, long-term conditioning management. So it's about starting with, you know, small areas and actually building on that. And I suppose making sure that the education is disseminated in a multidisciplinary way, because mental health is certainly an opportunity for that. Okay, thank you. And one for Sanjeev, I think, really fascinating in terms of, you know, how you've picked up the kind of auditing. What does it look like now? Who have we got? What are the gaps and all the rest of it? And what's the input from the Academic Health Science Network, from Health Education England at every different level, or is this a kind of united democracy of Islington? You know, it's the kind of, you know, how insular is this, and how widespread and how externally looking is it?
I think there's a recognition that actually the data available around the primary and community workforce is limited. And that inhibits making sensible plans. And so I think there is work going on at both national and local level to improve the quality of the data and the collation of the data. So the way I see it working is there's going to be a top-down approach run out of Health Education England through CCGs, I suspect, and local area teams that seeks to try and better understand the current workforce. Then there is a bottom-up approach that needs to happen as well, which is much more focused around the local context, not just in Islington, but really in all the boroughs across North Central and East London, where we've got to understand not only what is the current workforce, but what should it look like as we go forward. And it's about bringing the higher order level data and the lower level order data together, so that we begin to have a good sense of what is required for not just local communities, but also more broadly across a bigger geography.
Okay, that's helpful, thank you.
I guess if I can add one thing, it's really, you sort of touched on generic skills and capabilities. What are the challenges of establishing a set of generic skills and capabilities across an entire workforce when the history of the entire workforce is towards sort of less integration and more specialization at every turn? And how far have you got in identifying what those generic skills and capabilities are and how we might deliver them?
So I think certainly mapping to the work that we're doing, some of the generic skills may be around sort of really understanding the meaning of care coordination, really understanding how to have meaningful person-centered conversations. If we're really trying to understand what person-centered outcomes are, there is something about going back to basics and actually looking at how to have meaningful conversations with individuals. There is also something about the motivational approach and goal setting, which again is a generic skill which can be carried forward from GPs through to healthcare navigators. It's around really having that systematic approach. And there is also something about the values of an organisation, the way we communicate compassion, that sort of the method of communication which delivers that. So I think we've identified some of the key themes which are very sort of strategic, I suppose. We have the basis of multidisciplinary learning opportunities already in place, aligned to the co-creating health model of delivering that, of delivering the motivational approach. But I suppose the difficulty is how you begin to, create the dialogue with staff within different organisations to really support them in understanding that this is a meaningful and important thing to be doing. And I think that's the bottom-up approach. That's where it's going to take a little bit more time, and that's where there does need to be the sort of distributed leadership. It can't be top-down. It has to be understood from the bottom up, I suppose. And for us, I think the importance there is about really involving our patients and service users in that educational process, because there's no one that's going to tell a GP more eloquently about what they need than a patient. So that's another very key message. I think it's the co-production message.
Thank you. So just to push you on that, how much experience have you got of involving patients and carers in the initial education and the continuing education of healthcare professionals?
So certainly we have a number of experts by experience who work within the context of the sort of expert patient program, and are also very much involved in the teaching of the motivational approach, for example, to healthcare professionals. In terms of really systematically and strategically embedding patient voice into the work that we're taking forward, we have a body called the Making It Real board. And the Making It Real board is a collaboration of service users, many of whom are in receipt of personal health budgets, and who form peer networks. And so for us, that is the beginning of a translation of real patient voice, service user voice, into how we can begin to develop our educational processes and initiatives going forward.
Can I just add something to that, if I may?
Yes, please do.
It's that one of the issues that I keep seeing again and again is about the fact that actually the agenda for integration isn't going to really succeed without the development of relationships between healthcare professionals, health and social care professionals, but anyone looking after others, and between patients and healthcare professionals. And that the need to actually do very basic things like support, respect for patients, caring for each other, supporting each other is a sort of fundamental part of the journey. We talk about parity of esteem in relation to physical and mental health. Actually, we should talk about parity of esteem between different types of healthcare worker, because that, I think, is a fundamental challenge that we face within our system. And if we can begin to get to the bottom of that, we can begin to value all the different professional groups and the different types of worker that are currently working in the system to provide care.
Thank you, Sanjeev. I think that's very well put. I was struck earlier when I think Joe said that most of the workforce have worked in the hospital, but a much smaller proportion have worked in the community. And it may be in 20 years' time the opposite is true. And actually, that part of that process, that shift in the workforce, will change some of those relationships between different roles and different disciplines and professions within the workforce. I think from the work that we've seen in Lambeth, they have worked very hard to overcome some of those differences and taken a storytelling approach to try and change some of those attitudes and values, using powerful stories of patients' voices and experiences, but also frontline staff as well, to try and create a different narrative around how different, in this case, how different parts of the mental health workforce will work together in the future. I'm conscious that we are approaching the end of our session. I want to thank Joe and Sanjeev. Francis, is there anything that you want to say before we move on if you have anything you want to say to Joe and Sanjeev before we move on?
No, other than thank you, and now I know where you are, we can talk again.
Absolutely.
Excellent. Okay, thank you both. So if we move to the final bit of our agenda, Frank has shared with us something on his screen, which are some questions that have come in from our audience while we have been talking. And we've got three headings really, one around integrated teams, one on staff engagement, and one on predicting future need. And Joe and Sanjeev, you sort of touched on this in your presentation. I was wondering if we could start there. In particular, I'm concerned about planning for future need. Are sites mapping the workforce that they will need in the future, both in terms of demand and capacity? Is there anything you can add to this question?
If I may make some comments about that. Yes, one of the things that I've explicitly tried to encourage is getting our educational networks to start mapping the current workforce, their current needs, and potentially asking our educational network to think about what the future might look like. We've also done a little bit of work within the LETB, trying to sort of develop a strategy for the development of the workforce, particularly the primary care workforce at this stage. And we're trying to bring different bits of that work together to try and develop a composite picture. But again, using both the bottom-up approach through our educational networks, but also using the top-down approach through sort of workforce planning done at sort of LETB or Health Education England level.
Thank you, Sanjeev. I wanted just to move on to a question about integrated teams. Got three questions there. I think the one I want to kind of combine the middle, the second one and the third one. Frank, if you could just hold your cursor still for a second, it's slightly affecting our vision. Oh, there's another one appeared. That is amazing. The technology is always impressed. Anyway, we've talked about a life course approach, but the last question really is sort of what health and care professionals are needed in different integrated teams. I want to know how that might change over the life course. So do we need very different mix of people for different stages in life? I don't know does anyone want to have a go at that question?
Me.
Go.
The answer is yes, but actually I'd rather talk about skills than necessarily professionals, because if we continue to say a GP looks like this, a community nurse looks like that, then we'll miss some of the opportunity. So it's what skills and how do we have access to a different range of skills to support people at different times, I think is much more powerful, really. So it's people using a skills-based approach, and I really like some of the stuff Joe was talking about in terms of kind of motivational approach. It's also making sure that we identify the person who is best able to support individuals and their families around different issues, and sometimes that will be a very technical expertise, but sometimes it won't be. And there was a discussion about diabetes. Some of that is very technical, but a lot of it is helping people to manage their own care and keeping the confidence in how they're doing.
Yes, and I think a strong focus on individual well-being. So I suppose, and thinking about skills, it's not just skills within our conventional workforce. We must always be mindful to think about particularly the voluntary sector and the absolute wealth of opportunity and resource that that the voluntary sector provides, both in terms of the volunteer cohort, but also, as I mentioned previously, sort of experts by experience. So it's really about thinking how we can also systematically extend the offer of education and support and align the work that's happening within the voluntary sector to the very important work that we're trying to do.
Can I add that actually it will increasingly be teams that deliver care in such a way that actually we don't lose anyone through the segmentation of the population in the way we're talking about it. And that's really quite important, that actually populations and communities will receive their care through teams that may be virtual or physical, but nonetheless it will be teams that take responsibility for the care of people.
And so I'd be very interested to see what work Pioneer Sites have done in mapping the skills and capabilities over the life course, and thinking and what work has been done around how they change for patients at different stages. So I just want to touch on the last question, which has come from Wayne, who is in Worcestershire, and he says workforce issues are encapsulated in part by organisational development plans. I wonder what stages Pioneer Sites are at, and whether we could share plans and strategies between sites. And we did touch earlier on a sort of single OD and workforce plan across multiple organisations. I just wonder whether or not, let's go to Joe and Sanjeev with that one first.
If I may start, I mean, I think that one of the things that I've picked up as I've been going through this journey is that actually sometimes organisations become a barrier to effective integration, and the way around it is actually to encourage the development of relationships rather than try and think too hard about sort of organisational integration, and by keeping the patient at the centre of the focus, one can get around the sort of the challenges of trying to create organizationally synchronized OD plans, and that actually where they have emerged organically, it has been very successful. I think Islington's a good example of that, but actually beyond the geography, I've seen that happen as well, where there are huge challenges around trying to create organizational integration. Sometimes you can actually get great success by actually encouraging those relationships to form organically, and particularly around areas of need and for people in particular situations.
So I would certainly second that. I mean, I think it's there are so many themes that have come through from the conversations that we've had this evening. I think it would be very difficult to lift and shift a strategy from one area to another. I think the important message would be that there are clearly there's some narrative that's been learned from many sites, and I think that the theme around having these meaningful conversations and really listening to what we're being told, particularly by our workforce and by our service users, and building those relationships is really the key.
Fantastic. Francis, would you like the last word on this?
Wayne is the delivery support manager from NHSIQ that is working with us and with Waltham Forest. So we're happy to share everything, but I do echo Joe's comments that it's useful, but you can't necessarily assume that a one-size-fits-all. We're all starting from slightly different places, but equally we're very keen to learn if somebody else has got something cracked.
Indeed.
Fantastic. Okay, that's great. I think we're going to close now. Thank you to everyone. Thank you to our presenters. Thank you to Joe, to Sanjeev, to Francis. Thanks to Bob, who has gone off to complete his duties at the local NHS Olympics. And we're sorry that Jo was unable to join us. We know that she tried, and we hope that she's enjoyed listening. We're going to close. Frank, is there anything that you need to say about what happens next?
No, only to say that you don't have to, when looking back at this, watch an entire hour and a half of video, and that we'll be cutting it up into chunks and labelling them properly so that you can much more easily navigate when you go back in. And also that we'll be sharing those over the coming few days. And one other thing is look out for a tweet chat, which is going to happen in the next few days. A tweet chat is a Twitter sharing of learning event, which we'll be putting out more information about in the next few days, but that'll happen next week on the same theme.
Thank you. That will be my first ever Twitter chat, so I look forward to learning how that works. And our next Google Hangout is going to look at commissioning for integrated care, and that will be coming up in the next few weeks. So thank you all very much. Frank, you are going to take us off air.
Right now.